Good morning, everyone. I am Dr. Hamid Faruqi. I'm a consultant endocrinologist and head of Dubai Diabetes Center, as well as a professor at the MBR University of Health Sciences. This morning, I'm joined by Professor Muhammad Hassanain. How are you today?
Very good, Hamid. Thank you for introducing me. I'm a consultant endocrinologist in Dubai Health and a professor of medicine in Mohammed bin Rashid University as well.
It's always a pleasure to be in your company. And given that we are today here at the Emirates Diabetes and Endocrine Congress, I would like to seek your opinion about something that probably you and I grew up with, which was to focus on management of diabetes, laser sharp on just blood glucose control. That's not enough, is it?
You're very true, and just an hour ago or so, we were both part of the launch of the Type 2 Diabetes Update Guidelines for Emirates. And the idea of just focusing on the glucose control is an old-fashioned idea. Nowadays, we have to look on the person comprehensively. Specifically, if they have a specific risk for heart problems or kidney problems, where that would take precedence of specific type of therapy, even if their blood glucose level is quite well controlled. So we no longer just look into the blood glucose levels or the markers for it. Definitely we look into the person in totality, their kidney function, their eyes, their feet, and everything to decide on how do we progress with treatment.
So basically, we have moved on to the level that we should be treating our patient as a whole. It's not just diabetes in terms of the blood glucose that is important, and if we focus on it, if we control it, then all our problems are gone.
Very true. Precision medicine means I need to look into the person. So God forbid, if both of us have diabetes and we are comparable in age, we might be different. I might have specific health issues that dictate a specific line of treatment to be started versus another person who maybe their concern is their weight or their blood glucose levels. So Hamid, let me ask you, how did we come to that conclusion? What evidence do we have for this?
So basically, when we were in the glucose-centric mode of doing things, we went ahead and we said, hey, let's bring the hemoglobin A1C down to 7% or below. That's the target we chose, and the reason for choosing that target was, again, scientific evidence that beyond that point, we saw that the complications were taking off. So we said, let's bring the sugars down to 7% and we should see the impact of that. We did that. Two problems came about. One, the complications were still there, although lower, and as we kept on pushing the limits lower, hypoglycemia started to set in. And therefore, we were between the choice of trying to avoid the complications on one end, which were long-term, and on the other end, we had this short-term complication of hypoglycemia, as you very well know, has significant impact on the patient, not only at that time, but for example, the irregular heartbeat can continue, and that implication could be there for quite some time, maybe days. So then at that point in time, we said, okay, we probably then need to have a better grasp of what else is contributing towards those complications and how do we address those. And the two key players in that arena are high cholesterol and high blood pressure, and those are the things that we continue today to focus on to help us control those complications better. So in that realm, what data do we have with regards to the control of hypertension and dyslipidemia? What evidence do we have now?
It's a very important point because hypertension and high cholesterol are serious problems that we know about them for many, many people, but specifically for people with diabetes. Having these problems together, if I have diabetes and also my blood pressure is high or my cholesterol is raised, then it accentuates the problems. And there is lots of evidence that people with diabetes benefit a lot from lowering their cholesterol level with specific types of drugs, statins, and if not enough, other lines of therapy to get the LDL to a specific target. Equally, the blood pressure that is acceptable for a person with diabetes is different than the blood pressure is accepted for my twin brother that does not have diabetes. So that's really quite an important aspect. But I guess the issue goes beyond just blood pressure and cholesterol that we've traditionally known. Nowadays, we know that certain diabetes drugs are important. Do you want to shed some light, Hamid, on how do we select the choice of the drug based on the profile of the person in front of us?
I think before I answer that question, I would like to revisit something that is important in the choice of medications.
Yeah.
And that is the story about the TZDs.
Yes.
Right? So we at that point in time were so focused on getting the A1C levels down that we did not really focus on what harm or what else is that drug doing. So therefore, when we saw that yes, it was bringing the sugar down, but at the same time it was causing problems, we then moved away from that medication. So to answer your question, when we are choosing any drug for a particular patient, we have to keep in mind the first thing, which is each individual is unique, right? So let's take the example of metformin. That is our most commonly used medication. However, when we are choosing that medication, we have to make sure that the patient's kidney status is such that they can handle that drug. And in addition to that, as the treatment goes on, we need to keep an eye on the kidney function, which is not being damaged because of metformin. I need to reiterate that. This is a misconception that metformin is the one that is causing the kidney damage and therefore you should not be using that medicine. No, it is other factors that may be in that patient leading to the kidney functions going down. We need to continue monitoring that on a regular basis, and if and when the numbers show that metformin is not the way to go, we need to stop from that medication. So the first thing is that particular patient's profile. The second thing is what other concomitant problems does that patient have. For example, if the patient has already heart failure or has had a stroke or has cardiovascular risk factors, then we should choose an agent that not only helps bring the blood glucose levels down, but also helps us with the management of their atherosclerotic cardiovascular disease. And based on the data that we have, there are two classes of medicines that are important. One of them being the SGLT2 inhibitors, and the second one are the GLP-1 analogs. Now, we have tons of data that are showing us that both these classes of medications have a significant benefit with regards to their heart failure, for example, with regards to their progression of the kidney disease, so on and so forth. So I think it is better that we keep the entire patient profile in mind and choose the medications accordingly. Now, the thing is, we also need to remember that diabetes is a progressive disease. So for that reason, if we are starting off with a patient and that patient does not have a complication, somewhere down the line they will have that. So we then need to modify our treatment accordingly. The other important thing, or the last important point in this progression of the diabetes management, is not to delay and procrastinate what the next step should be. We should try to do it as early as possible and not try to wait out a long time before the complication sets in. Because our goal is honestly to prevent the complication. When you are managing diabetes, it is not just the fact that you have to bring the blood sugar down. The key of diabetes management is to prevent the complication and intervene early. So therefore, we need to keep an eye out for those complications and intervene as quickly as possible, particularly in the area of injectables. Doctors are scared about writing injectables, patients are scared taking the injectables, which include both GLP-1s and insulins, and we should not hold off on that for a long period of time. We need to intervene early in that regard.
With you, there is a lot of inertia by healthcare professionals for many reasons. Perhaps lack of update on the timely approach for the next step. Perhaps it's maybe the soft issues of giving an excuse after excuse. So we're heading into Ramadan now, and then the patient would come to me and say, "Doctor, it was Ramadan." Ramadan is not meant to be an excuse for poor glycemic control or poor control of the blood glucose. So I think we need to try to implement the steps for intensification of treatment and address the cause. Perhaps the cause is not the drug, perhaps the cause is the lifestyle of the individual. And as you have said, we need to look into the individual. So certain classes of drugs, if my heart or kidneys are at high risk, then there are certain drugs that are indicated, such as the SGL2 inhibitors or the GLP or GLP with GIP, that goes beyond the value of the lowering of the glucose for precisely for the protection of the heart and the kidney. And certainly the weight management as well. Many people with diabetes, they do have diabetes, but they also have a problem with their weight. Lowering their weight with change in their lifestyle, as well as with the drugs that can hit two birds with one stone, improve their weight and improve their glucose levels, are very effective nowadays and could actually lead to further improvement in their blood pressure. So, Hamid, in your opinion, and you're a director of one of the important diabetes centers, how can we overcome this inertia? It looks to me like there's a gap between what's written and what's actually implemented.
That's 100% correct. And one of the things I think we wanted to highlight when we launched the guidelines today is the fact that this is not a coffee table book. These are actual recommendations that are born out of data, of experience, that the healthcare providers should implement over time. So we have tried our best to make them as practical as possible and as simple as possible, and finally as relevant as possible to our culture, our needs, our environment. So I think the key there, in my humble opinion, is that this being a chronic disease, there should be a continuity of care. And I'm sure you will agree with me, the fact that when we have a person with diabetes, there is a lot of discussion that goes back and forth between the physician and the patient, which is the art of medicine, not just the science of medicine, in which we decide, okay, this will work well for this particular patient, but at the same time, not to go along with a poorly performing treatment plan for a long period of time, right? So if we can have a long-term relationship with regards to continuity of care. I think that, along with the guidelines that are in place, will help us achieve better blood glucose control. Because imagine if a person is seeing me for the first visit and is seeing completely somebody else who may or may not be following the guidelines, we may not be able to achieve what we are looking for.
Thank you.
Yeah. Are we good?